Oh, we are recording the session, which we will post on the journal website. We are going to have excellent, really incredible lineup of speakers today. This was organized by Alessandra Pedrocchi and Eleonora Guanziroli, who serve as guest editors of a special issue with focus on neurorehabilitation. They are going to run the webinar today as guest editors of the special issue that I just mentioned. We're going to have a few talks, relatively short, actually really brief, and then a panel discussion to go over future of neurorehabilitation and future perspectives, opportunities in this area. We have really fantastic papers that Alessandra and Eleonora will introduce. And so without further ado, I'm just going to let them take the lead and start the presentation. Thank you so much.
Thank you very much, Paolo, for promoting and supporting the organization of this webinar. Your vision and commitment to advancing research and research communication have been instrumental in bringing this event to life. So, my dear friend and colleague Eleonora Guanziroli and I proposed about 1 year ago a thematic paper collection titled Functional Recovery and Brain Plasticity. The goal was to highlight the pivotal role of neuroplasticity in the recovery process, emphasizing the synergy between sensory, neural, and musculoskeletal systems. Contributions span diverse topics, including digital tool, robotic system, and neuromodulation techniques. And this webinar takes place approximately 1 year after the publication of these articles. So it brings together again the authors and friends to discuss the current state of research and how their work has evolved since the publication, providing updated insights and exploring future direction. Each author will briefly present their work, followed by a panel discussion featuring all authors and a special guest, my esteemed colleague and friend, Professor Sylvester Hoehne. So now I'll hand the floor to Eleonora, who will introduce the speakers.
Thank you, Alessandra. It's my pleasure to introduce the speaker of today. The first one is Professor Franco Molteni, PMR physician and director of Villa Beretta Rehabilitation Center and the scientific director of the Villa Beretta Rehabilitation Research Innovation Institute. The Professor Hummel, professor at École Polytechnique Fédérale de Lausanne, holder of the Whittaker Chair of Clinical Neuroengineering and head of the Human Laboratory at EPFL's School of Life Science. Isabella Martinelli, PhD student at the University of Pavia and at Health Institute of SOS. Awad, physical therapist and rehabilitation scientist and founding director of Boston University's Neuromotor Recovery Laboratory. Now, please, Franco, to speak about the work on auricular vagus nerve stimulation and the effect on stroke patient.
Thank you, Eleonora. I share the presentation. I would like to share with you some experience related to transcutaneous auricular vagus nerve stimulation in post-stroke patient. This is an old story, and as recently this paper stressed, is a new player in brain-body communication, And we have a very important fMRI study related to activation of different parts of the brain related to auricular vagus nerve stimulation, particularly the insula, hippocampus, and thalamic region 2, using a non-invasive stimulation. And we know that there are relationships between vagus nerve stimulation and prefrontal cortex 2, where we have a lot of possibility to manage motor control and premotor area modulation related to intentional movement. That means that using this kind of stimulation, it's possible to focus on neuromodulation to facilitate motor recovery and neuromodulation to facilitate cognition in terms of recovery of cognitive flexibility and reaction to different stimulation related to interpersonal relationship. That means that we have just one neuromodulation related to a multi-domain activities of the patient. We have some experience about implanted stimulation in Houston, for example, and they are able to demonstrate that in chronic patient, upper limb function in stroke patient improve after implantation of vagus nerve stimulation. We try to have an experience in a small group. This is a pilot study, a small group of stroke patient using transcutaneous vagus nerve stimulation on the left part. And this is completely non-invasive. We use a frequency of 25 Hertz and 250 microsecond pulse width. And we perform around 10 minutes of stimulation. Then this is a pilot study in a small group of patients to check the acute effect of this kind of neuromodulation. And we test box and block before and after stimulation, and go, no-go task as a paradigm to assess reaction time of the patient, then related to cognitive function, to define if we have any acute effect of this kind of stimulation. This is the group of patients that we test. We test mainly subacute stroke patient, that means in the first 3 months after stroke, and some chronic patient too. Someone with right brain lesions, other to left brain lesion. And we use this kind of protocol, real stimulation and box and block, sham stimulation and box and block day 2, day 3, real stimulation and go, no go, and sham and go, no go test in day 4. Box and block seems a very simple test, but we have a lot of information because it is a test related to dexterity, related to coordination, related to visual motor coordination of the patient, that is very important. And we test a lot of different cognitive function of the patient, but particularly we focus on go, no go to evaluate selective attention. Results. If you look box and block on the affected side, we don't have any acute effect in terms of statistical power on the acute effect on the affected side. If you look the non-affected side, we have 2 main results. First of all, using box and block, you demonstrate that the non-affected side before stimulation on the right or left part of the body is impaired because we have normal data, 71, and no one of our patients reach more than 45, 48 blocks in 1 minute. And we realized that using an acute effect of this kind of neuromodulation, right hemiparesis on the non-affected side increase the ability to perform box and block. Then we have a statistical significant result just on the right hemiparesis, non-affected side means left hand. If you look the go, no go, you realize that you have a reduction of the time that means more selective attention of the patient just on left hemiparesis. Then we have two different effects with the same neuromodulation, depending on the brain lesion that we have to focus, and we have to try to using an acute effect of this neuromodulation to test if we are able to change. Then, to summarize, box and block is a test of dexterity, go-no-go, selective attention. We are able to facilitate recovery of function of the non-affected side on left brain lesion, and we are able to facilitate selective attention recovery on right brain lesion. This is just an acute effect, a small group of patients. We mix some acute and chronic patients. By the way, there are a lot of reasons to try to focus on this kind of neuromodulation. Very easy, non-invasive, possibility to start very early, possibility to use it at home. Obviously, we have to increase the population and to improve the ability to detect exactly the effect of this kind of neuromodulation. Thank you for your attention.
Thank you, Franco, for your presentation. So, the next speaker is Professor Hoehne, that will show us the effect of low intensity focus ultrasound for stroke recovery.
Thanks a lot for the invitation. So now I'm unmuted. Yeah. So I would like to discuss with you briefly new ideas of how we can target in a non-invasive fashion deep brain structures in the framework of neurorehabilitation, ideally. So why this? Because it's very clear that in the process of adapting to a lesion in the brain or to retrain functions which are lost, deep brain structures, like if you think about memory functions, the hippocampus, or if you think about motor function, the reacquisition of motor skills, deep structures like basal ganglia, striatum are very important in this process. However, for a long time, targeting these deep structures was limited to invasive approaches, like classically DBS, what you know probably from Parkinson's disorders. However, now with their new methods, which probably allow us to target these deep structures, these important deep structures like hippocampus, like striatum, in a non-invasive fashion with still a very high focality without stimulating the overlying cortex. This is not possible with very classical non-invasive neurostimulation methods like transcranial magnetic stimulation, or let's say classical transcranial electric stimulation like DC-AC stimulation. So I'd like to give you today a brief overview where we are standing with the main technologies which probably allowed this deep brain stimulation in a non-invasive fashion. This is focused ultrasound, and this was we reviewed here the literature for this issue. I will give you also a brief overview of another technique which is emerging at the moment. It's an electric stimulation technique which also allows probably to target deep structures. And both of these techniques have different advantages and disadvantages. So it's not like they're directly replaceable by each other or comparable to each other. They have different advantages. So if you think about focused ultrasound, obviously is highly focused. The resolution is in the millimeter range, which obviously you cannot reach with electric stimulation probably. On the other hand, and I will come to this in a second, probably the parameter space for neuromodulation is probably still needs explorations rather for focused ultrasound and a bit less for electric stimulation. I will come to this in 1 second. So just to summarize briefly which parameters play a relevant role for focused ultrasound, there is a relevant amount of parameters starting from the sonic duration into stimulus intervals between your pulses you are applying, the pulse width, also the different frequencies you are applying here, pulse repetition periods, duty cycles. So these are all parameters which relevantly impact on the effect you might want to achieve with neuromodulation, from how long the effect persists, whether it's rather an inhibitory effect or rather an excitatory effect. This is still an area which I guess there are not yet very established, completely clear guidelines. It's still an area which needs more scientific exploration also. Also in the terms of mechanisms of action, they're basically, probably one can summarize it in three main hypotheses of the effects, and probably they are all relevant depending again on the parameter space which is applied with focused ultrasound. It's a thermal effect which probably impacts on thermosensitive ion channels, and a mechanical effect which impacts on mechanosensitive ion channels or cavitation aspects. What is very interesting, and it's getting also more and more information about it, or evidence for this, that probably the effects of focused ultrasound are not restricted only on basically on neurons, but also probably on astrocytes. And this makes it then also apparent that probably stimulation effects might differ whether you apply it to gray matter, which is most of the work done so far, or to white matter. In terms of clinical translation, there are several approaches have been started and ongoing, for example, for major depression, targeting the prefrontal cortex, but also leverage, in my view, this advantage of targeting deeper structures like the amygdala or nucleus accumbens, which are relevant areas in several neurological and psychiatric disorders, for example, anxiety, substance use, or then it's also in several ongoing studies targeted areas, deeper structures for in Alzheimer's disease. In terms of neurorehabilitation, despite a big potential of targeting structure, which are important for rehabilitation, for example, for motor rehabilitation like thalamus or again basal ganglia, most of the models are still in animal stroke models done. What is very interesting in these animal stroke models, there is also evidence that focused ultrasound might also impact on immunological aspects, which are important for the recovery process, not solely on changes in excitability. In terms of application of focused ultrasound for neuromodulation in stroke, for recovery, there are only at the moment case studies. So there, I think there's more work needed and to be exploited. So now I want to show you probably in the last 1-2 minutes another approach based on electric stimulation, which is very well suited to target deep structures like the hippocampus here, for example, in the framework of spatial navigation task, where stimulation of the hippocampus combined with a training of or encoding of spatial memory leads to a benefit of encoding and retrieval, or in the framework, if you think about the framework of motor learning and reacquisition of skills for rehabilitation, targeting the striatum combined with motor training leads to an enhancement of training in short term. So this is very prone then also to translate into clinical applications for rehabilitation. I just want to give you one very brief example of a first proof of concept where this has been applied in traumatic brain injury patients who basically received the striatal stimulation while they did the motor training. And this led, even in a very short training of 30 minutes, it led to a slight improvement of the training effects. But what was much more important is if they come a day later back and perform the same motor task, then there's a benefit of the motor task, which was trained with the Wearable stimulation compared to a placebo stimulation. So to conclude and to open the discussion, I guess we have now opportunities with focused ultrasound especially, but also with temporal interference stimulation to target deep structures. And this could potentially be really transformative in terms of clinical translation. Also, as pointed out, there are several neurological and psychiatric disorders and in rehabilitation where these deep structures play a critical role. Stroke, Parkinson's, dementia, and others are just examples for this. However, there is still need more work to better understand the mechanisms and define the parameter space, which is optimal then for the clinical translation. And by this, thanks a lot for your attention.
Thank you. Now I will call the next speaker, Awad, that will show us how to promote neuroplasticity in the chronic phase after stroke, the effect of a soft robotic exosuit.
Okay, good afternoon, everyone. Can everyone see my screen? Wonderful. Okay, so my name is Awad, and I'm an associate professor of physical therapy at Boston University, where I also direct the Neuromotor Recovery Laboratory. So my talk, I'm going to show you how our lab is using a software exosuit to enhance exercise-induced neuroplasticity in patients who are undergoing gait rehabilitation. And first, I want to make sure I acknowledge our fantastic team at the Neuromotor Recovery Laboratory that bridges traditional disciplines, spans multiple institutions. Our team members come from medicine, physical therapy, engineering, with homes in both industry and academia. And I'm really here just to present, their work. So to dive right in, when clinicians analyze walking impairments, there are many ways that they can do so. And a simple biomechanical framework that I like to use starts by breaking down the gait cycle into a repeating sequence of 3 locomotor tasks: body weight support, propulsion, and advancement. Disruption of one of these subtasks or transition from one subtask to another leads to a dramatic impairment in walking ability. The rest of my talk is going to focus on how we are using a robotic exosuit to treat impairments in the middle propulsion strategy used by patients to accelerate their bodies from step to step. And a lot of my team work is actually based on this idea that impaired gait propulsion is one of the most overlooked and undertreated gait deficits that limit the recovery of walking after neurological injuries like stroke. And on the left, I'm showing you a trace of the anterior, posterior, and reaction forces that are produced by the impaired paretic and the non-paretic legs during the single gait cycle of walking. And you can see this dramatic asymmetry across limbs where the paretic limb generates lower magnitudes of force earlier in the gait cycle. And the functional consequence of this is in that top right panel, where I'm showing you the relationship between paretic propulsion output and the gold standard clinical measure of posterior walking ability, the 6-minute walk test. And so as a general rule, patients who generate low levels of propulsion can't walk very far. And not only do we generally lack propulsion targeting treatments and technologies, but actually one of the most common interventions that we see after stroke is the ankle foot orthosis. And not only does the AFO fail to support propulsion, but it actually hinders physiological propulsion by preventing the plantar flexion of the ankle that's needed for propulsion. And so in contrast to ankle foot orthoses, our team at Boston University and at Harvard have been working to advance soft robotic exosuits that are worn in parallel with the impaired underlying muscles to restore the control of propulsion. And over the last 7 years, what we've learned is that when used under the supervision of a physical therapist, the exosuit can help patients walk with reduced gait compensations, improved gait mechanics, and a reduced energy cost of walking. And more importantly, patients can go faster and farther when they're walking with the exosuit powered on and providing assistance compared to walking without the exosuit on at all. But our goal is not just assistance, but also rehabilitation, where we can exploit repeated testing, repeated use of the exosuit across sessions to promote biological recovery. And so to that end, we've started to harness the exosuit's ability to support propulsion in various settings from simple to complex environments. And in the next few slides, I'm going to highlight the results of our paper published in OJEMB as part of the special issue and the results of a follow-on clinical study related to the application of the exosuit as a rehab robot. So this study was led by a former PhD student, Anna Roto, who asked the question, can soft robotic exosuits enhance exercise-induced neuroplasticity? And to evaluate this, she recruited over 15 people in the chronic phase of stroke recovery to provide blood samples before and after a bout of maximal effort, high-intensity exercise, once with the exosuit and once without the exosuit. And from those blood samples, we measured the concentration of brain-derived neurotrophic factor, which is a blood biomarker of neuroplasticity. And jumping to the results, what we found is that we can harness the exosuit to facilitate gait training at higher cardiovascular intensities and for longer exercise durations, resulting in an increase in blood circulating BDNF. And the most important finding is that we did not see the increase in BDNF in the same patients when they completed the same exact task without the exosuit. And so since the original publication, OJEMB, we built on that work and just completed a single-arm mechanistic clinical trial that enrolled 25 patients and provided them with 4 weeks of session-over-session exosuit-augmented gait training. And our outcomes are still in preparation, but I want to share them with you. The presses here during the webinar. We've observed substantial pre to post-training improvements in multiple domains of walking ability assessed without the exosuit on, including increased pedic propulsion, faster walking speeds, farther walking distances, all surpassing clinically meaningful thresholds and retained after a 1 month no intervention follow-up period. So we just completed these analyses. They're still in preparation. We have a paper review. Keep an eye out for. And I'll stop there. Thank you.
Thank you. Now, the last but not the least, Isabella will show us a new digital method to analyze human figure drawings as a tool to assess body representation distortion in stroke patients.
Thank you. Can you see my screen, right? Perfect. So good afternoon to all of you, and thanks a lot for the invitation. Our work was focused on the use of human figure drawings as a way to evaluate body representation distortions in stroke patients. Indeed, human figure drawings are often used in clinical practice as a way to evaluate distortions of body representation, especially in neurologic patients. The main objectives of our work were first to present the Kudrow app, which is a custom-made application in MATLAB that allows the digital analysis of human figure drawings by extracting both quantitative and qualitative parameters, including, for instance, the type and number of visible body features and the dimensions of body segments. The second aim was to investigate whether Kudrow app analysis could reveal distortions of body representations in a sample of drawings realized by chronic stroke patients. To reach this aim, we performed and compared the data generated manually and digitally by 2 users of the Kudrow app. And we computed an index of asymmetry for the upper and the lower limb as a measure of body representation distortions. What we found was that basically the data generated manually and digitally were characterized by strong and positive correlations. Regarding the drawings by chronic stroke patients, we found that overall they presented a lower number of body features compared to drawings by healthy controls. And we also found that the upper limb that corresponded to the site of the most severe sensory motor deficit in these patients were more distorted than the lower limbs, while no difference was found for healthy controls drawings. There are some outlook that we are currently working on. First, we we studied the lesions, the brain lesions associated to arm and leg distortions measured from the human figure drawings. We ran a voxel lesion symptom mapping for both arm and leg index of asymmetry, and we found that a set of brain areas were associated with greater upper limb distortions. And the interesting part is that these brain areas we know that are important for multisensory processing, motor aspects, and body representations, while no association were found for leg asymmetry, for the leg distortions. We are also working with the group led by Professor Andrea Bandini from Scuola Superiore Sant'Anna to implement machine learning and reduce the user input to perform drawing analysis. And apart from this, we are, of course, working on other projects, especially at the affected limb perception questionnaire study, which is an ongoing study at Villa Beretta and SHUV that has the aim to investigate explicit alterations in the perception of the affected limb in stroke patients. And we are working as part of my PhD on a new study on healthy subjects to investigate the effect of vestibular stimulation on such representations. And with this, I thank you for the attention.
So, Alessandra and Eleonora, I just want to be sure that you notice there are a couple of questions in the QA box. The first one was for Professor Molteni and ask if, Franco, you could clarify how the parameters, the stimulation parameters were chosen. And the next one is from Dr. Martinelli and Isabella. They were wondering if you assessed neglect in these patients, if there was a relationship between your findings and the severity of neglect.
First answer about the parameters that we have to use. We use 25 Hertz, depending on the experience that the group that using auricular vagus nerve stimulation is 25. There is the possibility to use 100 Hertz. Obviously, we have to increase our experience, and maybe that pupillometry will be a system to detect if 25 or 100 Hertz will be for the patient the best stimulation that we have to perform. There are some possibilities to use EEG2, and particularly to check alpha band. Obviously, in this moment is related to just to research, is not in clinical practice, but maybe that we will have in the near future the opportunity to define if 25 or 100 Hertz are the best stimulation parameters for the patient.
Isabella, would you like to answer?
Yes, sure. So thanks for the question, first of all. Indeed, neglect is one of the fundamental aspects to take into consideration when dealing with drawings. Unfortunately, for this group of patients, we just had a measure of the general cognitive functioning, and we had some measure related to attention. But in order to control for this aspect in a new group of subacute stroke patients in which we are collecting human figure drawings, we are also better characterizing the neuropsychological profile, including, of course, the neglect. And we are also asking additional questions to understand which is the perspective that the patients use to draw, in order to know also how the affected arm is represented, so if shorter or longer.
So,
There is a... Yes,
Eleonora,
I can take it.
if I may, I'm just going to allow one of the attendees to speak. This is something that we usually don't do, but Steve Wolf is on the call. And Steve, if you were actually going to be so kind as to share your experience, right? And Franco is certainly aware of the fact that Steve was part of the trial that was published in the Lancet with some of our colleagues at MGH actually leading that. So Steve, any comments on the vagal stimulation?
Sure. Well, thank you, Paolo, and thank you for the speakers for the very interesting and entertaining presentations. I think with respect to transauricular VNS stimulation, one is when the optimal stimulating parameter have not truly been determined, it may not just be a question of frequency, but also the stimulation duration and intensity as well, raises the interesting question that with a very limited vagus representation in the ear, might it not be appropriate to actually consider personalization of the stimulating parameters so that one can look for what might constitute the best response, at least from a motoric point of view, for each patient individually, simply by tweaking those parameters to find the best response? I'd be interested in hearing what you have to say.
Excuse me, I think that if we have to discuss about personalization, maybe that we have to define different frequency, but maybe the side. Because, for example, in our small group, we stimulate the left side. We don't have any experience in this different group to stimulate left or right side. There are some discussion about where is the best place to put the stimulation, not only the parameters that we have to use, but maybe that we have to combine left or right and different stimulation to personalize.
May I respond to that? Well,
go ahead, Steve.
I think those are excellent points. Those are precisely the points. The use of auricular stim is really at its infancy right now. As you know, for the percutaneous or invasive VNS, the left vagus nerve is chosen for some very specific reasons, dealing with some of the autonomic functions or dysfunctions may occur with excessive vagus nerve stimulation. But you're raising some very interesting points. This is still very exploratory, not to dismiss the importance of auricular stimulation, but to define what's best. And I would really encourage continuous work in this area. It's at its infancy right now, and I think could benefit a great deal by further work. Just one small point that I also raised that's been known for quite some time. In stroke, there is no unaffected side. The so-called unaffected side is affected as well because, at least as we know, 20% of the cortical spinal system is uncrossed. So the finding that there was some differences in what one sees with the so-called unaffected side and that not being normal has been known for quite some time. So I would encourage us to refer to the affected and the less affected sides, if you will. Thank you.
Thank you very much. Let me go on with this point, which I think it applies to neuromodulation in general. I would like to have the opinion of Professor Micera and Professor Hoehne especially, but maybe also of the other panelists, about how to deal between developing neurostimulation, neuromodulation solutions, and so giving solutions and design on the one side, and keep the personalization on the single patient as a key point in the final deployment. Because if we need to start from scratch for each patient, we will never end up. And so there is somehow a balance or some compromise to be.
Riedel, you want to start? I know you. maybe I can quickly, I mean, first of all, thanks for inviting me. Really very interesting webinar and very nice presentations. Let me say that in general, my first impression of most of the presentation reminded me of a Danish philosopher, Søren Kierkegaard, who was saying that one of the problems of the contemporary people, of the modern people, is the amount of choices that we have. No? In the medieval age, you have only one thing to do. You do the farmer, or you are the king, no discussion, or the knight, whatever. So the idea, the issue of we have two issues. Personalization, which mean, I mean, they were discussing about transauricular, where we do it, how we do it, and so on. So just the position is important. But then you have how you select the stimulation parameters. And then in addition to that, you know, think about that. We saw three different approaches, very different. You know? We got soft exoskeletons, cortical neuromodulation, autonomic neuromodulation, okay? So let me say that the issue here, and it's going to be really, with some of the people here, we wrote a few years ago a review perspective paper exactly on this topic. I think we need to understand a bit better what we are doing to find a way to combine it. But clearly in the long term, that could also be a solution. Depersonalization of the specific device, of the specific neuromodulation approach, I have a small bias, as most of you know, but I think has to go through modeling and algorithms. So clearly the issue is the more you go for many parameters, you know, cortical modulation could be done with many ultrasound probes, could be done with many electrical probes. You can combine different kinds of neuromodulation techniques. Then the question is how you can deal with the increased complexity of the parameters. So let's say on one sense, you need to try. I totally agree. You need to test, let's say, to enter the field to get an idea, to smell what is really possible. But sooner or later, creating some options, more options in terms of personalization through modeling. But modeling could be machine learning, could be biophysical models, could be whatever. We can discuss later if you want. I think understanding the basics, what you are really doing on one side, and using models for understanding and personalizing, it's the next step. And the other thing that maybe some of the option, maybe not the cortical, but as Franco knows, for the vagus nerve, I'm a bit, let's say, more interested in the invasive solution. So it could even be that in the future, I mean, the transcutaneous is advantageous because it's simple and it's non-invasive, but maybe not super easy to have all the information. So let's say, but that's another story. Going back to Alessandra, very important point, modeling in different ways, it's a very important step, together with some preliminary testing, no? Because I mean, you need to at least to get data for the modeling.
Thank you very much. I'm curious of freedom.
Yeah, no, I mean, I guess I would start with the point that we need to be always become aware and now be aware that a one suits all solution just doesn't exist. And in this sense, also to go a bit away from very classical, I mean, the ones from you who come from very clinically oriented way, go away from classical large clinical trials with no selection of patients, right? I think they are costly, they take a lot of time, and at the end we learn that the treatment doesn't work for everybody. But this said, so coming back a bit to, let's say, rehabilitation and stroke recovery as a model, I think there's another aspect which comes not from the technology by itself, but also from the understanding of the disorders. We need probably models which represent at least more groups of patients than very simple models. I give you one example. I mean, there's this classical interhemispheric maladaptive inhibitory model, which is still for a lot of approaches in, at least for brain stimulation, used like, you know, chondrolesional hemisphere, even not affected or non-affected, but chondrolesional hemisphere is probably better to inhibit it, and the lesional to facilitated. But there's now very good evidence that this is definitely not a case for every patient. It depends on in which phase a patient is after recovery, rather in the acute, subacute, or chronic. Then it might also depend if the lesions are rather small subcortical lesion or large cortical lesions. And then it might also depend on how severely somebody is impaired. And just there, and this goes a bit in the way what Sylvester said, we can use now modern, for example, imaging technologies, let's say structural connectivity approaches, where you can see clear association that, for example, the degree of damage to the cortical spinal tract is associated to the relevance of secondary motor areas in the process of recovery and in response to neuromodulation. So one side, yes, technology, but the other side is also understanding of the disorders, in which phase of the disorder are we, and what kind of the functions we want to target in which phase, right? And then to make it a bit more complex, also is, I mean, one aspect is to up or down regulate excitability locally, but as we know that our brain works strongly as a network machine, and probably, if possible, focusing rather on modulating interregional interactions, probably is another aspect of which might be relevant for personalization. Yes, in parameter space, what I feel sometimes in the community of neuromodulation is probably taken a bit too easily, is that, I mean, neuromodulation is not equals not neuromodulation, right? You have really a parameter space where you can impact on, you can entrain ongoing oscillatory activity, rather impact on plastic properties, or simply change cortical excitability. And this is not similar. So it depends really what you want to achieve. And it's big fun to be together here.
Thank you very much, Frida. I have a question for Luis. So modeling, personalization, pathophysiology understanding, everything applies also to robotics, which is a hard science. That's it?
Thanks for calling that out. I was going to chime in, but the question wasn't about robotics. So we've actually been developing what we call a phenotype-guided approach to personalization of the robotic stimulation. We're not tackling it from a physiological perspective, but using movement as a window into the underlying physiology. And what I mean by that is we've created these 4 subclasses or subtypes of people post-stroke based on their performance and the quality of that performance. So to be more specific, you can take people who walk fast and people who walk slow, and it's a speed-based classification. That's not a really good indicator about the quality of their movement. So if you take fast individuals, you can further classify them as highly asymmetric and not as asymmetric, mildly symmetric. And the same for slower individuals, high asymmetry versus slow asymmetry. And you could think about this continuum. The least impaired individuals would be the fast symmetric, and the most impaired individuals on the other end of the spectrum would be the slowest and most asymmetric. And what we've been doing is devising ways that we can apply the robotic assistance, the magnitude and timing of that assistance specific to the phenotype of the patient. So I'm not sure if that would have value in the neuromodulation space, because we're clearly movement-based in terms of the robot is assisting the movement of the individual. But the general idea of modeling or subtyping or classifying patients seems to make a lot of sense across these different interventions.
Thank you very much. I have a long-standing question for Franco. Franco, we are more scientists. You are a real clinician, dealing with patients in everyday life. What do you see as the major, let's say, challenges for a real effective clinical translation of these technologies? I mean, we all know that in your clinics you are using them, but what is the next? What do you see as the major barriers and challenges?
We have, I think, two main problems. The first one is education of physicians to appreciate technology, and education of the bioengineer to appreciate biology. Are the two different aspects that we have to face, because first of all, we focus on brain lesion as a physician, and sometimes we think that the parameter of the system that we are using is something unrelated to the biology of the system that we would like to change. And in the same time, sometimes bioengineers focus on technology without any consideration related to biology of the system. For example, Luis presented an excellent example to use a soft robotic system on a tapis roulant. One of the key points is that using a soft robotic system, it's possible to move over ground outside the gym, and you change completely the neuroplasticity of the system, just related to the fact that you move from a tapis roulant to outside. Then it's a key point: education on technology for physicians, education on biology for technicians.
Thank you very much. I totally agree that education is one of the major responsibility we have in this field. And let's conclude with the quick, each speaker giving a comment about a final comment. So major technical issues, major clinical barriers. Let's start from, who wants to start? Sylvester, you are always ready, born to be ready. But you are mute.
And of course, no, I'm almost ready. Now I am. No, but I mean, I think that this webinar really showed that there are many, many opportunities in the field. But, you know, what we said, myself, a bit, Friedhelm, Louis, and Franco now, we have to grow up more in the mutual understanding between the different people and among the different disciplines. And at the same time, understanding a bit more what we are doing. You know, I mean, you know, for many years, it was kind of, okay, I design a robot and I test it. I make cortical neuromodulation and I test it. And then so on, you can name it. We need to work more together on the understanding of the basics of what we are doing. Because, you know, otherwise, it will be impossible to reach the complexity of the design, personalization, combination of it. Because, you know, now we have many combined solutions, but at the end, combinable, integratable solution. We don't know really how to do that. So working together, understanding more the basics of what we are doing.
I can catch up on this with the point. I think it's even what Sylvester said in terms of starting and thinking of a project or of a device that we very, very early on, even in the planning phase, try to bring the different expertises together. Because I think in both directions, we saw it often enough that either we clinicians start with something and then later on engineers say, well, you could have done it much better, much earlier and much more successful, and vice versa, that nice devices are designed, but never a clinician was kind of involved. And then later on, you realize, man, if you would have known all of these things, including the underlying neuroscience, well, we would have designed it together much more successful. I think that's one important point. And I think the other one is very clearly one suits all solutions. They don't work for a lot of patients. I think we have to very early on go away from this and be clear who we target. But then the treatment or the technology is also probably only for a subgroup of a patient group, not for everybody, which is, in my view, not an issue. I mean, then for the other group, the technology will be adapted or the treatment will be adapted.
Isabella or Luis? Ladies first.
So I'll go. Of course, I agree with the other speaker. Maybe one additional point would be, when feasible, to involve also patients and to consider also patients' reported outcome in the process of neurorehabilitation, with the aim to personalize the rehabilitation program, taking into account also the point of view of the patient.
Yeah, I really appreciate what they're saying. The one thing that I would want to say to kind of end the conversation here and is I think oftentimes the technology developers think about how we can build technologies that can be used in the current clinical space. But oftentimes some of these technologies have the potential to completely alter how we do things clinically. And so I love the idea from Friedhelm about bringing the clinicians together with the technology developers in the beginning, not to just envision new technologies that can be used in the current clinical standard, completely change that standard and what will really be needed from early development through implementation to change the standard once the technology is built. I think technology has so much potential to change not just our outcomes that we see clinically, how we deliver those outcomes as well.
Thank you very much. I think we have touched some keywords of the field: education, back to basic for a real impact, interdisciplinarity from the beginning, tailoring of target populations, the patient's point of view, and technology as a living, changing being, which is a super interesting suggestion. So I let the floor to Eleonora to conclude.
Thank you to everyone for this presentation. Thank you for all of the contribution, and thank you, Paolo, for this opportunity.
Well, thank you very much, Sharon and Leonora, for serving as guest editors of this fabulous special issue. And thank you for organizing the webinar today. Thank you to all the speakers for their contributions to both the presentations and the discussions, as well as attendees. Thank you for connecting today for this excellent webinar. Thank you very much. Again, we will wrap this up, and the recordings will be made available through the journal website.